Let's go ahead and pick up where we left off last time. We were talking about the internal cavities and their fluids. Posterior cavity behind the lens filled with vitreous humor, supporting the structure of the eye, clear so light passes through it easily, keeps the retina pressed against the choroid so that we don't get retinal detachment. If you do have problems with retinal detachment, that means you have a problem with your vitreous humor in that area. A little bubble occurred. The retina then is not flat against the choroid, bubbles on up, and so that will not receive the light rays that are actually hitting it properly, and you'll get some abnormal information sent to your brain. And if it stays detached, because it's not attached to or abutting the choroid, not attached, but abutting the choroid, that area of the retina will actually no longer get the nutrients it needs to survive, and you'll actually end up with then death of that area of the retina. So whenever a retinal detachment occurs, doctors want you to go in right away so that they can go ahead and laser tack it, so to speak, back in place and hopefully get restoration of your vision. Anterior cavity, aqueous humor, two areas, anterior chamber, posterior chamber. The dividing line is the iris. In the posterior chamber, we produce the aqueous humor. It's produced 24/7, just like CSF. And then it moves or circulates through the pupil into the anterior chamber. It is actually full of nutrients. So that's one reason why you'll have increased glucose in the bloodstream will also be reflected in your aqueous humor and therefore cause visual disturbances in the cornea of individuals with type 2 diabetes, undiagnosed or poorly treated. The scleral venous sinus, or the canal of Schlemm, is what's going to actually drain the overflow or excess aqueous humor. In our picture here, it shows you it's at the scleral corneal junction, or corneal scleral junction, however you prefer to say that. It's within that area, so it's in the anterior chamber. And the excess aqueous humor will drain out of that area, and that drainage will keep the pressure inside the globe at an appropriate level for a healthy retina. If you increase the pressure because of inadequate drainage, then you will actually increase the pressure applied to the retina, and you'll basically be squishing that retina and destroying those photoreceptors. Once these neuronal cells are destroyed, they never come back, and so visual loss will actually occur. I want to go back, and before I go into supplies, nutrients, and oxygen to lens and cornea, I want to go back to the macula lutea and fovea centralis, because don't forget about that topic called macular degeneration. When people experience macular degeneration, if you know of anybody that has it, you should ask them where they are experiencing their visual field loss. It's in the very same area that we just talked about. Things that go straight back that you're looking at straight on are designed to actually hit the macula lutea and fovea centralis, because that is the area where cones are in highest concentration. Cones give us our highest clarity or visual clarity. And so everything in the center of your field of view is going to your macula lutea. When you get macular degeneration, that means you're getting loss of the cells of the macula lutea, and so that means you're losing your vision right in the center. You can still see, but you can't see things in the center. You can still see things in the perimeter or periphery of your vision. So people with macular degeneration, they learn to actually look at things not straight on, but off to the side. They still can see their world, but the visual clarity is definitely impaired. Aqueous humor is important because it is like CSF. It's not just water. There are also sodium, potassium, glucose, various nutrients in that, as well as oxygen, and of course some carbon dioxide. So the aqueous humor is going to be there to actually supply nutrients and therefore oxygen to our lens as well as the inner aspect of our cornea. What's really fascinating is that your cornea is gas permeable, which means that gases can move back and forth. And oxygen in the outside world can easily move through the cornea to help supply nutrients to the cornea and a little bit into the aqueous humor, but mostly to the cornea. And if you have excess CO2 being produced, then CO2 can easily off-gas into your environment. So your cornea is gas permeable. In the days of old, when they first developed contacts, the material that they used in contacts was not the material that they use today. And it was actually made out of glass. And so they would take this glass and they would shave it on down and file it on down to a smooth surface to actually be like a lens and apply it over a person's cornea. The problem was it completely covered the cornea. And that's what you have to do if you want the lens to actually work. So it completely covered the cornea, and people who wore the first contact lenses they were restricted in the amount of time that they could wear them, because when you are basically slapping an impermeable Band-Aid over your entire cornea, you are losing out on the oxygen transfer you get from the environment, and so you actually can seriously damage your cornea and decrease the oxygen content inside the aqueous humor area. So that's why after a while, some people still require rigid lenses, but those rigid lenses are now gas permeable, and you don't have to worry about that. You can wear those lenses for a long period of time because of that. Let's talk about our lens. It is a biconvex, transparent, flexible disc composed of lens fibers. And that's what I want you to realize. Transparent and flexible. That's something that a preserved cow eye specimen cannot help you appreciate. And that's why it was nice if you had in your lab a fresh specimen that had previously been frozen, because you could see the beautiful transparency of the lens, and the more you handled it, the more it got mushed and smushed. So it is indeed really flexible. It is within that capsule that has fibroelastic fibers making it up, that is designed to actually, when stretched, it will flatten it, and then when things relax at the perimeter with the suspensory ligaments, then the lens is able to spring back into its form. The other thing is it is biconvex, so bi means both sides. And the way I remember convex versus concave is I am very vexed when my belly protrudes. So biconvex is protruding and concave is going in, and that's typically what you do to a cave. You go into a cave, and so convex would, if you're looking at it from this side, convex would be protruding out, or if you're looking at it from this side, concave would be nice inward aspect to it. So our lens is a biconvex, transparent, flexible disc composed of lens fibers. It is avascular, and it is still living. And that's why it's transparent and flexible, because it is still living. So that aqueous humor is exceedingly important in making sure that lens stays healthy and nourished. The fibers inside the lens are densely stacked and packed proteins called crystallins. And if you were curious enough and cut your lens in half, you would have noted that the lens itself is layered. Those crystalline fibers are layered in that lens like an onion. The capsule is fibroelastic CT. Suspensory ligaments are attached to its periphery. So the perimeter of the lens, as well as its capsule, are where our suspensory ligaments or ciliary zonules are actually attached. This helps keep the lens in place. And the tension on the ligaments directly impacts the thickness of the lens. Lots of tension, thin lens; very little tension, thick lens. One more thing I'd like to talk to you about the lens is that sometimes we get these things called cataracts, and most people think of cataracts are of the lens, but let's realize a cataract is going to be a clouding of a previously clear area where light has to pass through. So the first thing light has to pass through in order to get to the retina is the thing that actually provides the most bending or refraction of light, and that is the cornea. The next area that light will pass through is the aqueous humor, and then it will pass through the lens, and then it will pass through the vitreous humor before it actually gets to the retina itself. So all of those areas can have problems. One reason why we don't have problems with the aqueous humor is it's produced 24/7 and removed. So it would be very unusual for us to lose our ability to see because of problems with that, other than if it's not draining properly, and then we get increased pressure causing glaucoma and loss of vision from basically sitting on the retina and destroying it, so to speak, with too much pressure or weight. The corneal transplants are often done for corneal pathology, not able to see through well, and clouding of the cornea. So if you put a fresh cornea on somebody's eye, then you can actually help to restore vision. So that's one area where you can, quote, get a cataract. The other area indeed is the lens, and then the last area is the vitreous humor, vitreous body. It's not uncommon for our pets to actually have genetic problems with their vitreous body. If their vitreous body becomes unhealthy, because what you're born with is what you got, it isn't really replaced. And so if it starts to get clouding of the vitreous humor, then you will actually block off light to the retina. And many of your animals that you look at, and they have these nice dilated pupils, because obviously they're not seeing, and kind of a whitish look to them, well, very commonly the actual defect is in the vitreous humor. Now for humans, that's not a problem like it is for our pets, like cats and dogs, but for humans, more often, the most common area that you get cataracts in is in the lens, because the lens, actually, as we age, the lens loses its ability to become so pliable or flexible. And when you lose that ability to be pliable or flexible, because think about it, light, what does light do to your paint on your car? It starts to oxidize it. So that lens, as long as it's healthy, it's going to be great. But over time, it's not unusual for some people to experience the damaging effect of oxidation of that lens, or light rays passing through it, and it starts to become less healthy. When it becomes less healthy, let's attach the word pliable or flexible to it, and it starts to kind of get more dense or firmer on the inside, and that shows up as opacities. The other thing to realize, if it's less pliable, less flexible, the ability of nutrients to actually travel to the center of the lens from the aqueous humor is seriously impaired. So that loss of flexibility also will impact the ability of nutrients to actually dissolve and diffuse, simple diffusion into the center to keep that area healthy, because the lens is still considered living tissue in you and needs that nutrient supply. The interesting thing, because we have a capsule around our lens, we can actually, and it is kept in place by the suspensory ligaments, as well as our vitreous humor in the posterior cavity, we can go ahead and do replacements of our lens. Cataract surgery is what that is referred to. And so you make a little cut into the cornea, and then you go ahead and put a thing called a trocar. You actually pierce the fibroelastic capsule, and then you put a suction in it, and you literally suck out the lens because it's that pliable. After you suck out the lens, you have a collapsed capsule, and then you take your intraocular implant and put it through the little cut. You have to extend it if necessary based upon the implant, and you put it on in and you drop it into the capsule, and then you go ahead and close your external incision area in the cornea. You don't sew up the capsule. It will heal up on its own, and then you actually have a new lens. And you can see it's nice and clear, and the only problem is it has no ability to get fat or skinny. We have not yet been able to come up with a way to have a nice pliable lens replacement in people's capsules. Physiology of vision, refraction and focusing of light. Light rays, even though they're wave-like, are straight. They travel in a straight line. And they must hit the retina where the cones are concentrated for our best vision. If we want to see really nice, crisp edges to what we're looking at, we want to activate our cones. And that's typically in highlight situations. And we want to hit that macula lutea and fovea centralis. Now, in order to do this, because light's coming in and it's being, things coming off to the side are coming in, and when we look at something far away, we don't have to worry about having to bend the light rays, but the closer things get, we're going to have to actually apply some bending of the light to actually get that thing that was far away now coming big and taking up all of our vision, even beyond the macula lutea. We want to get those light waves bent to make sure that they hit the macula lutea and more preferably the fovea centralis. Bending of light is called refraction. And we use lenses to bend the light when we want to actually take a look at the eye and take a look at how we actually focus. Light can be bent by using lenses and the curvature of the lenses, or it can be bent by passing through different clear media which have different densities. So we know air is less dense than water, and so that's what our picture is of over here. We have a spoon in a glass cup of water. So when we take a look at this picture, the information coming to us is actually only passing through air before it gets to our eyeball. In this area, it's passing through air and water, the information about that spoon handle. And then in this area, this information is coming to us after it has passed through or been bent by water, the glass, as well as air. Air doesn't bend it much. Glass in this instance is not really bending it much, but water is bending it. Water has quite a bit of density here and indeed can be used. That's why we use oil on oil immersion lenses. We use the refractive capability of the oil to help us see the image larger. And indeed, you can see with this, with just water, that it does have a magnifying effect. Remember, light is passing through, when it gets to our eyeball, it's passing through the cornea, the aqueous humor, the lens, the vitreous humor, as well as the different cellular layers of the retina before it actually gets to our photoreceptors. The other thing that we do to help bend light is we use lenses, and we use the curved surfaces to help us in this process. So let's take a look at the curved surfaces of lenses. A lens, our definition, transparent object curved on one or both sides. So it means that you can actually have a flat side on one of the sides. If the lens is convex, remember you're vexed if your belly is protruding, that curve is outward, and that causes light to converge. If you are concave, that means you are curved inward, and that causes light. It's a funny looking thing up top. Hang on here. I don't know why it's looking like that. Causes light to do the opposite, to diverge. This may not be intuitive for you, so let's go ahead actually and move up and have a light ray coming to a convex surface. So let's go ahead and hit just a convex surface. When you hit that convex surface, depending upon, hang on, let me erase this part. When you hit that convex surface, as long as you hit it right smack dab in the middle, it's relatively flat, and so the light ray is not bent much. But if your light hits the lens off to this side here, it will cause the light ray to actually bend. So same thing down here, converge. The opposite happens with a concave surface. So now I'm going to make my concave surface here behind this. I'm going to have my light coming in, light ray coming straight on in close to the middle. So when it hits it, it isn't deflected. But if we hit up in this area, we experience a bit of a 90-degree related angulation, and it diverges. So that's how we use lenses. And the lens surface on the other side can be flat, or it can be curved. And our lens is biconvex. Let's talk about how we focus for distant vision or near vision. We cannot change the nature or shape of our cornea, our aqueous humor, or our vitreous humor. So the thing that we can change the shape of is our lens. And so that is what we actually manipulate internally whenever we are viewing at anything in the distance or up close. So we are manipulating the thickness of our lens whenever we're looking at things, whether it be distant or close. And a process where we are actually contracting the ciliary body, which will then decrease tension on the suspensory ligaments or ciliary zonules, is called accommodation. So accommodation is performed by the ciliary body. It's a contraction of the ciliary body and occurs for near vision. So this is something that we do when we want to take a look at something up close. At first, you are confused because I brought your attention to the suspensory ligaments or ciliary zonules. They're attached to the perimeter of the capsule, and if you have tension high on them, you're pulling on that capsule and you're flattening the lens. The only way that you can actually relate this in real life, or you can memorize it, is to take a look at the direction of the fibers here of our ciliary muscle. So we are looking at the ciliary muscle from a posterior aspect. So we're taking a look at things from behind to up front. The ciliary muscle, if you notice, has fibers like a certain type of fiber in the iris, circular fibers, circumferential. So think about this. If we contract the ciliary muscles of the ciliary body, what will that do to this tension that's being applied to the ciliary zonules or suspensory ligaments. So our ciliary muscles circular, and we have all these suspensory ligaments going off to this lens in this area. And when you contract the ciliary body and the ciliary muscles, that will cause this to become smaller around that lens. So if you're smaller, the lens doesn't change size. What happens to the tension? You're now closer to the lens. What happens to the tension on our ciliary zonules? It actually decreases. So if you decrease the tension on the ciliary zonules, you will fatten up your lens. So contraction of the ciliary body is what happens when we undergo that process called accommodation. We want to take a look at something up close, and so we will contract our ciliary body, which releases or reduces tension on the ciliary zonules, which then will allow the lens to actually be nice and fat. So let's go ahead and take a look at, I'm missing something here. Distant vision. And close vision. So we're taking a look at things in the distance here with number 2. That's what this means by looking at the mountains and the forest here. Things are far away. We don't need to have things so magnified. We need to get things to the retina, and the eye is actually designed for things to actually, from a distance, to be kind of a general information stuff, not needing a lot of, quote, focusing. And so what's nice about this is that the lens doesn't need to be fat, it needs to be flat. So in distant vision, the lens is flatter or thinner. That's easier for you to remember. And our ciliary muscles, in order for it to be thin, the tension on the suspensory ligaments has to be high. So then the ciliary muscles have relaxed. Remember, this is a sympathetic process. We are trying to scan the outside world to see where we need to go to get away from whatever could possibly be threatening us. So the ciliary muscles, when they are relaxed, that is a sympathetic process. For close vision, in order to see things and the details of things up close, just like a microscope, we need to magnify it, so to speak. And in order to do this, the lens is thicker. This will bend light more. So in order to do this, the ciliary muscles contract, which means the tension on our suspensory ligaments is lessened. And then this allows the lens to actually get thicker. So this is a parasympathetic parasympathetically controlled process. When something's up close, that's kind of like rest, digest. And so we are wanting to take a good view of whatever it is that we have up close, and we want to have our dinner. So we get a good view of it, and we make our lens nice and thick. And our pupil is also small because we're not worried about what's coming at us. We're just taking a look at that which is right up close to us. And that's another aspect of looking at things up close. We'll get to that in just a moment under constriction of the pupils and accommodation. Our notes go to the near point, which you guys did in lab or at home. That was part of your lab exercises. It is our closest point of clear focus. So when you take your hand and put it all the way away from your face and you slowly bring it toward your face, it is that area, under good light situations, by the way, it is that area where you can actually still see all that wonderful detail clearly. Once that detail becomes fuzzy, you have passed your near point. The near point is absolutely dependent upon how thick the lens can easily become. As we age, we lose our elasticity, all that, all those photons passing through the lens. We'll lose our pliability, we'll lose our excellent nutrient flow, diffusion, and it will cause our near point to increase. So near point increases. Remember how you measured near point in lab. It was how many inches or centimeters this object was from your face. So as you get older, does your near point get closer to your face or further from your face? And it gets further from your face, so then it makes sense when you say the near point increases. In other words, no longer are your arms long enough. And so then you'll use lenses to actually help you with that loss of elasticity or accommodation or fatness of your lens. The last couple of things here, when you're looking at things up close, we will get constriction of the pupils. This will enhance your effect of accommodation. It helps you to just focus on what is right in front of you. Remember, accommodation is for close-up vision. So we're not worried about what's in front of us. We're not in fight-flight mode. We're in rest-digest. The pupil gets smaller and allows us to literally just focus on that which is right in front of us. So near vision. Fat lens. Better magnification allowed then. Also, you know that when you are looking at something up close, your eyeballs literally converge. So the convergence of the eyeballs, what that means is that we are looking now, instead of straight in front of us, we are now looking at the object in front of us, and our eyeballs are moving nasally. In other words, our medial rectus muscles are contracting. This is indeed a requirement for close vision. Controlled by the oculomotor nerve, and we get activation of both medial rectus. Activation and contraction. Both medial rectus muscles, which of course are skeletal muscles. Let's take a moment and look at a few vision problems and we'll stop there. Emmetropia is the term we use for normal vision. So if you don't need any glasses, you see great. Maybe even 2015, you have emmetropia. Myopia is the term that we use for nearsightedness, whereas hyperopia is the term that we use for farsightedness. Nearsightedness means that we can see things up close. The things that we can't do is see things in a distance. So in other words, we can't see things far away. Now, this is typically not a lens problem. It is typically due to an eyeball issue. And for this, what ends up happening is the light rays end up getting focused, finding a focal point actually in front of or before the retina. So focal point is in front. So the focal point is what we create when we are bending our light rays. So we're using refraction to make everything come to a nice focal point, which is what we want for focusing on our macula lutea and fovea centralis. So we want all those nice light rays to actually converge or bring all that information into the area for best clarity, which is that fovea centralis, and we still get excellent clarity with the macula lutea. It's just not as beautiful as the fovea centralis. So our picture here with emmetropia shows something that we're looking at. Things are coming in, and indeed they are getting bent by the cornea, and they are getting additionally a little bent by the lens. And so that lens is allowing things to hit that macula lutea fovea centralis. In myopia, there's a couple of things that can actually happen for you. It can be due to the eyeball being too long because the cornea doesn't change, the lens is trying to do its job, but the focal point keeps moving away because the eyeball's too long, or maybe if you want to say too fat, but I prefer too long. So if the eyeball's too long and all of your construction was designed for that focal point to be right here, as it was over here, then you no longer are getting the visual clarity that you need. You're actually getting, after that focal point, you're getting those rays to actually diverge back there. So the focal point or focal plane that they're talking about right here is very important. If your eyeball is too long, then the focal point is where it should be, but it's not on the retina. It's in front of the retina. Another thing that can cause that to actually occur is if the lens is if you have a lens, let's go over here. If we have a lens that is, what can we do to make the focal point occur in front of the macula lutea and fovea centralis? We can make that lens fatter. So if the lens is too fat, we'll bend the light rays more and the focal point will actually occur in front of the retina. But that's not the typical case. The typical case is that the eyeball is too long. But don't forget, a super fat lens can bend light rays more and cause your focal point to also be in front of the retina. Hyperopia, farsightedness, you can easily see things in the distance. But you have difficulty seeing things up close. The nice thing is if you cannot conceptually remember the difference between myopia and hyperopia, just memorize one and realize the other is the opposite. Hyperopia, farsightedness, can see in the distance, can't see up close, and therefore this is because your eyeball is too short and the focal point is actually behind the retina. So going back over to our picture here, erase some of this. Going over to our picture here, if we shortened our eyeball, our lens and our cornea and everything else is doing its job, and that makes the focal point behind, indeed, the retina, and that causes the difficulty seeing things up close because you cannot seem to easily get your lens thick enough to help bend the light rays to get you to that proper focal point. You just can't get that fat. It's got its limits, so to speak. So our story here is focal point is behind the retina, and this is due to eyeball too short, or if the lens is too thin. And that's why it's typically not a lens-related issue. It's typically an eyeball length issue. Astigmatism, unequal curvatures in different parts of the cornea or the lens. Your cornea is supposed to be nice, smooth, and symmetrical, but sometimes we have some asymmetry, and it's that asymmetry in the cornea that will give you astigmatism related to information coming in that area. Astigmatism is easily fixed with lenses. Also, if you have asymmetry in your own lens internally, that can cause astigmatism, but we still are able to correct that with artificial lenses externally. Our next topic is phototransduction, and I'm going to go ahead and stop there for right now and leave this YouTube for you guys to actually finish reviewing before we come to our next lecture, which is Wednesday. So this recording is for our missed Monday lecture class. There are no internet clickers associated with this lecture until Wednesday. So I hope you guys are able to enjoy your Martin Luther King Monday off, and stay safe and stay warm.